the meeting. And first up on the agenda is to talk about or vote on the minutes from our most recent meeting, which was the September 3rd meeting. Does anyone have any amendments to propose to those minutes? I think I sent around with the first, hang on. I think, sorry, we just had a note taker bot enter the meeting. I'm going to ask that we remove the note taker bot from the meeting. If someone, Amelia, could you look into doing that for me? Thank you. Anyway, does anyone have any amendments to the last meeting's minutes? Great. I'm going to take that as a no. So can I, oh, yes, go ahead. Go ahead.
So I was going to just say I didn't see any hands raised or anything. So I moved to approve the minutes of the September 3rd, 2024 Value Plan Work Group meeting as presented.
The second motion?
I'll second that.
So we have a motion and a second. Are there any questions or concerns? Hearing none, the minutes are approved.
Thanks so much, Evelyn. Great. Thanks, everybody. So on the agenda today is basically just to talk through the changes that we're proposing, given the 2026 actuarial value calculator. So we've got some things for you all to discuss. And just jump right in. I'm gonna kind of ground our conversation by giving a little overview of the maximum out-of-pocket amount. So if you don't already know, the maximum out-of-pocket amount is the maximum an enrollee will pay towards in-network covered health expenses in a plan year. So this is not the deductible. This is kind of like worst case scenario. If someone's having to pay a lot for care, this is the most that they'll end up paying under their plan. The feds set the limit for the maximum out-of-pocket every year. And so obviously our plans can't have maximum out-of-pockets or MOOPs that exceed the limit. And this year, the max is a little bit higher than it was last year, quite a bit higher than it was last year. So the max is $10,150 for dollars for all metal levels, but the silver variants. So then in the silver variant plans, it's a little bit lower depending on the plan. And then in a couple of years ago for a different work group, we had the MIA looked into how many people actually meet their maximum out of pocket. And it's a very low proportion of enrollees that actually end up meeting their out of pockets, 2 to 5%, depending on the metal level that the people are enrolled in. So again, this is not an amount that most people end up encountering. And because of that, we see the maximum out of pocket as raising the maximum out of pocket as a way to reduce a plan's AV and allowing us to keep other co-pays and other forms of cost sharing lower. And in doing that, kind of isolating the impact of that change to this smaller proportion of enrollees and keeping costs lower for people in general. So, for example, raising the MOOP is, going to affect fewer people than raising the copay on generic drugs, which a lot more people have to use generic drugs than have to end up paying the full amount of the MOOP. So this is just how we're thinking about maximum out of pocket. And as we've kind of talked about in this group before, and the approach that we've taken in the past is to go to raising the maximum out of pocket amount first before we touch the cost sharing for other services, again, as a way to kind of reduce the impact on the the plan design and how people are experiencing it. So with that being said, I'll just get into the proposed changes and everybody kind of buckle your seatbelts and I hope you can stick with me through this. So starting with bronze, so as I said, the first approach will be to raise the maximum out of pocket to the maximum allowable. So to 10,150. It was 9,200 in 2025. Doing that for the bronze plan does not get us to an AV that's low enough to comply with federal requirements. So we have to pick one of the options listed on this slide. And the ideas that we developed in consultation with our actuaries and with the MIA are to either raise the specialist copay to $110 or raise the copays that we currently have set at $35, which we have linked to get together, like that we have, if we change them, we change all of them. So the suite of services is primary care visits, mental health office visits, and then physical, speech, and occupational therapy. Raise those, which are currently set at $35 to $40. So those were our two original recommendations. And if you were following all the changes that I sent by email, these were the original that we recommended, or not recommended, but this was the original proposal we put forth. And then Care First has come through with some suggestions as well that we thought were worth bringing to you all for consideration and discussion. Their idea is to kind of split the impact on copays between the specialist copay and the labs copay. So still raising that move to the max like we need to do anyway, and then raising specialist to $105 and then labs to $60. And we had originally, you can remember back to summer and fall, we talked about reducing lab copays as our kind of effort towards health equity this year, reducing those lab copays across the board, and we'd reduce them from 80, which was the 2025 amount, and in the bronze in particular down to 55. But in this, in this proposal, Care First is saying, well, maybe instead of bringing those down to 55, bring them down to 60. And then raise the specialist to 105. So of those three options, I'm going to show you the spreadsheet now just to illustrate for you. I figured I'd go through meta level by meta level and just show you how that looks on the spreadsheet. So since that might be a little bit easier to visualize the difference in between these options. So bring that up now. So here is here are the relevant kind of changes. So as I mentioned, and I'll kind of try and I can annotate on the slide. So ignore this. We're just looking at bronze right now. So as I mentioned, we have to keep the AV at a certain amount. So we have to keep it below 65 for the bronze plans. All of the recommendations, or not recommendations, the suggestions fall under 65, and there's enough room for us to continue offering the $0 diabetes suite of coverage. So those are all fine. All three options require us to raise the maximum out of pocket to the maximum allowable at 10,150. Or that's the deductible, sorry, but it's the same for this plan. And again, we have a lot of pre-deductible coverage in the bronze plan. So, it's high, but these are still usable plans. So anyway, we're setting that to the maximum allowable. And then, as I mentioned, the three options are kind of raise specialist only or raise PCP, mental health, and physical, speech, and occupational therapy to 40 from 35, or Care First is saying, why not raise specialist to 105 and labs to 60? So now that I've illustrated that for you all, I'm going to pause there to see if anyone has any thoughts or preferences or points of discussion. would like to hear.
Hi, Becca. Good morning. This is Kakia
Hi.
Perez with Kaiser Permanente. I had a question, and maybe this is directed to Care First with their option with raising both lab and specialist just $5 each. Could they give any background to that preference? Is it higher utilization of a specialist over lab, or just any background as to why that option?
That's a good question. I think Nikki is on from Care First. Nikki, would you be willing to speak to that?
Hey, Becca. Yeah, I am on, and thanks for the question. I'm gonna have to take that. Sorry for that. That back to our actuarial team. They were the ones that designed the plans, and I don't have any utilization data on hand right now, but I can definitely follow up offline with you, Becca, and send that around, or send it to you so you can send it around.
Thanks, Nikki. Any other thoughts? Right. I know we unfortunately don't have David Stewart on today. He wasn't available. But I know he is often able to speak from a navigator perspective to which copays and which services consumers are most concerned about when they're shopping for a plan. I don't know if there's anyone else who works with consumers directly on the call who could maybe speak to that.
I'll go ahead and speak to that if you'd like. I think it's important to keep the $35 suite of copays in place. I don't think it's negligible, honestly, between the 100 and 110 or 105 for the specialist. I don't feel that it makes a huge difference. I think it's more important to keep the primary care and the lab down. So I like that original one where we're gonna keep everything at 35 and raise the specialist to 110, but keep the labs as low as possible.
I agree, Becca. I'm here from Healthcare Access Maryland, the connected entity organization for the Central Region, so Baltimore City, Baltimore County, and Arundel County. So David Stewart is a colleague since he's out there covering Far West. I agree with what Lisa just stated. In my experience, when I was a navigator, it's more important to keep that copay for PCPs and those other services down. I don't think that $110 is going to be too significant, especially when you consider the type of people who go for these plans, right? You don't want people getting hit with $40 because they need all three of those. They need all three of those services, right? So with just thinking about the type of people I used to enroll in bronze plans, they normally don't need a specialist. They're just interested in being able to access their PCP. And then if they need a lab, just let them pay the $55 on the rare occasion that they might have to get some blood work done. But no, I definitely agree with what Lisa said. I think option one is the best option.
Hi, this is Tim from Aetna, and I agree 100% with the comments thus far. I think my preference would be option one as well. It keeps it simple and it keeps the PCP and kind of linked copays at a very low accessible level. So I like that as well.
This is all great feedback so far. Thanks, everybody. I'm hearing that, yeah, in general, there's a lot of support for option one because it keeps primary care a little more affordable to folks. Allison, yes.
Just wanted to add KP favors option one as well.
Thank you. All right. Anyone else have any thoughts before we move ahead to the silver plans? Great. Okay. I'm going to switch back to the PowerPoint and keep moving ahead. Thanks for bearing with me. All right, so here we have a big old list of the silver options. It is a lot of information, but it basically boils down to similar differences to what we saw for the bronze options. But I'll go through them. So starting with the base silver, again, for all of these, we're raising the maximum out of pocket. And as a reminder, we had split the maximum out of pocket into a medical out of pocket and a prescription drug out of pocket. And this way, people don't have to hit. People spend a lot of money on drugs, and like they don't have to. They need more prescriptions. They don't have to hit their entire maximum out of pocket for them to hit their max and then have the cost of those covered. So splitting it up is a little more consumer friendly. We can keep the drug deductible or the drug move lower, and so that's just background on that. That's why we have these split up. So for the base silver, we are proposing, or one of the suggestions here is raising the max out of pocket for medical, reducing the drug max out of pocket a little bit, and then having a total max out of pocket of $9,800, and then raising the specialist copay again to 110 from 100, like we did in the bronze plan, or in the option that people seem to support for the bronze plan. And then the Care First offered another option for consideration, which is to raise the medical max out of pocket, but by not as much as we're proposing, keeping the prescription deductible at $1,500. And then, so the total max out of pocket is $9,700 instead of our $9,800. And then doing the same, splitting the increase to copays across the specialist and the labs. Specialist to 105 and then labs to 50 from 45. So to kind of summarize that, well, I don't know, I'll just summarize it when we go to the spreadsheet, and just move on for now. But so for the silver 73, the suggestion is to again raise the maximum out of pocket, which we have to do on all of the plans basically. But yeah, again, reducing the prescription MOOP a little bit, having a total MOOP of 8,100 and raising the specialist to 110. And then Care First's offering is to basically have the same overall total max out of pocket, with a slightly higher prescription deductible, or not deductible, MOOP, sorry. And then doing the same thing, splitting the impact to copays across specialists and labs. Silver 87, we don't really have any options there. We're just gonna recommend that we raise the medical MOOP, and that's all we have to do. And then for silver 94, we could either raise the MOOP only, or Care First offering is raise the MOOP but by less than what we had originally proposed, and raising labs to $10 from $5. So that's a lot. I'm going to show you the spreadsheet again. It'll be a little bit easier to look at. And I'm trying to decide if I should just do that now, or there's another kind of piece that I have here on the slide about the rehab copays. And I think
let's hold on that piece and then have the other piece of the conversation first.
That's a good call. Thank you, Johanna. Yeah. So let's just baseline look at the summary of proposed changes on the spreadsheet, and then we'll return to the slides for to a discussion of another, like a more specific issue. So starting with the base silver over here on the right, we have to keep it under 72 AV with room for diabetes. All of these options, or both of these options rather, are in compliance with that requirement. And then you can see there's like a slight difference in how we're, these two options approach the maximum out of pocket, a little bit lower medical in the Care First option, a little bit lower prescription MOOP in the originally proposed option. Overall, ours is a little higher, but then in the second option, the copay impact is split across specialists and labs, and the original one is just an increase to the specialist copay. Thoughts on that before we go to the 73? Allison?
Yes, KP favors raising specialist only over raising both specialist and labs.
Thank you. Anyone else?
I agree with that. I would only raise the specialist and keep the lab and the primary care suite with primary care and lab and everything. I'm sorry, the specialist, I don't know if I said that right. The specialist I would raise, but the lower copay on the lab and the primary care.
I agree as Tim from Aetna. Prefer the proposed base at the 110 specialist.
Okay, thank you.
Becca, this is Brian from United. I would also agree with those comments.
Okay, so in the same vein as the feedback on the bronze plan, it sounds like people are favoring only touching specialists and not touching those lab copays. Okay, I'm gonna move ahead for the sake of time. But yeah, at any time, feel free to raise a hand with comments if I'm moving too fast. Right. So for 73, it's basically the same consideration. So unless anyone chimes in otherwise, I'm going to assume the feedback on 73 would be similar because the difference in the proposals is even more slight here. Like it's the same max out of pocket, but the first option is for touching only specialists, and the second one is to split that across specialists and labs. And so I'm assuming people feel the same way about preferring the option one to only touch specialist. 87, like I said, all we have to do there is raise the max out of pocket, so there's not much to discuss. And then for 94, the consideration for 94, just that one. So columns K through or H through L here. We wanted to, even though, we wanted to present this one because the max out of pockets are significantly different. Our first proposal was just to raise the max out of pocket by raising the medical component of it I don't think that's the maximum allowable, but it is higher than the second option. And the way that this lower max out of pocket is being offset in this second option is by increasing the labs from 5 to 10. And so again, in the same vein as the feedback we're hearing so far, I'm assuming that the feedback will be to keep labs lower but I do want to let people weigh in on that.
I'll weigh out on this. On this one, I disagree with what we said on the first one. I do like option 2. Because it's a silver 94, I think it's better to keep the MOOP lower, and raising labs from 5 to 10 isn't going to make a huge difference on this one because it's low overall. So I think keeping the MOOP lower I like option 2 better this time for this one.
Yeah, this is Kevin from WellPoint. I agree with what Lisa recommended. You know, the transparency and the deductible and out of pocket was significant in what was proposed. And I agree with what Lisa stated.
Okay. I'm also seeing a lot of thumbs up icons. So it sounds like there's some consensus around that. And then I wanted to, I think, for at least the base silver and silver 73, the way that we approach, and the bronze, the way that we approach those, I think Johanna and I had talked about that needing to be the same, because of the kind of, we try and have like a stair step approach. Like if, you know, we want the bronze plans to be lower than the base silver and the base silver to be lower than the silver 73 and so on. So we wanted that approach to align. I'm not sure if that applies here because the specialist is that accurate?
I think we're good with either the proposed option or the second option that Care First had put forward that seems to be the preferred option from the group. So I think either of these will match our stair step kind of goals, but Brian or Adam, if you're on and see differently, please jump in. I mean, Brad or Adam, if you're on and see differently, please jump in.
No, I agree.
That's great to hear. Okay. All right. So it sounds like up until the 94, everyone prefers option 1, and then at silver 94, we're hearing consensus around option 2. Great feedback. Thanks, everyone. Okay. So if there are no other comments on the silver options, I'll move ahead to the gold. Okay. So here we have a summary of the gold options. We have 2 options. One is to, okay, I see someone's dropping off. Thank you. Okay. So one is to only raise the max out of pocket. And then the second option would be to raise the max out of pocket, but keep the max out of pocket a little bit lower and raise the generic drug copay. So let me show you that on the spreadsheet. Looks like Tim has raised a hand.
Yeah, I may have jumped the gun a bit. I apologize, but I think I'm from Aetna and I'm supporting the option 1. I'd like to keep the generic RX lower. So that first proposal looks good to me.
Thanks, Tim. You did not jump the gun. That's what we're looking at right now. Yeah. So yeah, to summarize, or to, I guess, illustrate, the difference in the max out of pockets is quite significant by almost $1,000 here. But in the first, the drug deductible, or generic drug copay is lower. And the second option, while it would keep the max out of pocket a little bit lower, it would increase the generic drug copay. Any other thoughts?
Becca, can you also
Yes.
point out the difference in the how the MOOPs are compounded,
Yes.
because the prescription MOOPs are different?
Yes, thank you. That's a good point as well. Although our the first option has like a higher overall max out of pocket and higher medical max out of pocket, the prescription max out of pocket is lower than it is in the second option. So the way that that's distributed is different, although the overall is a little lower in the second option. So Justin.
Yeah, thanks, Becca.
Hey, Becca, I have a question. I'm inclined to, also like the proposal that keeps the generic copay lower, but I am curious, and I guess maybe the answer is we don't know, but I really am curious to understand why the other proposal might make sense. I mean, is there any sort of explanation we might have as to why that could be preferable for consumers?
So we don't have the folks on from Care First to speak to that, I think.
I think I can speak to that.
Jason, okay, great.
Yeah, so really it's just that you're going to have a much lower out-of-pocket maximum with that option. And yes, the generics will go up a few dollars, but it, negates that huge, $1,800 or so out-of-pocket max increase with option one, going from $6,750 all the way to $8,500, a little bit of a gap. The other option just kind of, lowers that a little bit. It's still going to increase, but not nearly as much.
Thanks for speaking to that, Jason. Ken, do you have a thought?
Yeah, my question is, earlier in the conversation, you said that the number of enrollees that are actually hitting the maximum amount of pocket number is relatively small. Is that holding through all the plans?
Yes, yeah.
And you can kind of see that equivalency in the actuarial values, because these have almost the same actuarial value, which is telling us that the impact of increasing that generic copay by $5 is roughly equivalent to increasing that maximum out of pocket by $1,000, because so many people have the generic drugs, relatively few people hit their MOOP, that small generic increase is roughly equivalent to that big MOOP increase.
Yep. All right. Thank you.
All right, so sounds like preference for keeping the generic drug copay lower, and the higher maximum out of pocket is what I'm hearing. Okay, well, if anyone has any other thoughts about that, feel free to weigh in at some point during the meeting. I do want to go back to the issue we said we'd go back to with the silver plans. So I am glad that there seems to be consensus around which options to go with, and then there's just this other piece for consideration, and I'll go back to this slide to kind of ground us. So this issue here about the physical therapy, speech therapy, and occupational therapy copay, and it's really the habilitative and rehabilitative services copay issue and the silver 94. And I wanted to give the floor to some of the carriers who've raised this as an issue to kind of walk us through the issue and talk about the proposed change. And I can share actually the spreadsheet again because it shows kind of what we are talking about. So I will invite, I think, CareFirst and Aetna, who were interested in bringing this up to the group. Yes, Allison, thank you.
Sure. We're one of the carriers who brought it up, Kaiser Permanente, and this is really just cleanup of something that we missed in previous designs. It's a general principle that HAB and rehab cost share should align with physical therapy, speech therapy, and occupational therapy. The best way to describe this is that physical therapy, speech therapy, and occupational therapy are all HAB and rehab, but not all HAB and rehab is physical therapy, speech therapy, and occupational therapy. There's just a lot of overlap. So when there are different cost shares, then the carrier has to make a call on which cost share to apply for physical therapy and occupational therapy. So what we're proposing here is just to align these cost shares at $5 to ensure we're applying the correct cost share.
Becca, this is Tim from Aetna, and I would concur. Allison probably said it more eloquently than I can, but basically, yeah, we always seek to keep those aligned to avoid confusion. So yeah, 100% on board with that.
Okay, thank you. And then, yeah, just to illustrate for the group, in all of their plans, we have, speech therapy and occupational physical therapy, the same as habilitation and rehabilitation down in this other section of the spreadsheet. And then in 2025, we just neglected to keep those together and left these at $2, but it is, as Allison mentioned, often the same services. And so what we're proposing is making sure these are aligned. That's the proposal. Any other thoughts on that? Or questions?
Would that change impact other cost shares? I mean, because I'm in agreement with it, but would it impact the results of the other cost shares that we have on here?
It would not.
Okay.
Because
yeah, then I would be in agreement.
Okay, thank you. Yeah, the additional standard service categories are not part of the AV calculation.
Perfect.
Okay. With that, those are the proposals and options we have for you today. And yeah, very interested in any thoughts or any feedback if you haven't already aired it. And otherwise, I want to present an opportunity to vote on all of these options. Actually, what I'm going to do here, this is a little inaccurate. Well, I guess we can, so in the silver 94, we said we liked option 2, and the silver. Sorry, just a second. Okay, I think that's accurate. Thank you for your patience. Right. Okay, so it's more like this. So we have the 3 options in the bronze plan, 2 options for the silver base and 73, 2 options in the silver 94, 2 options in the gold plan, and then this HAB rehab copay proposal. And it looks like a lot, but we did just talk through it all, and it seemed like we had consensus on a lot of it. So,
So Becca, we did a lot of talking, and we came to a consensus when we were going through the plans. Is it possible to change what you have here to represent what we discussed and what we all agreed upon, so we're not having to choose between 1, 2, and 3? We choose what we already voted on or agreed to during the presentation?
That's a great idea. I will, let's see. Okay, so I'll go through, and how about I highlight what we talked about as being the preferred options. So we talked about number 1, so the specialist, only touching specialist in the bronze. Talked about only touching specialist in the lower silver plans. We talked about the silver CSR. We liked option 2, which was raising the labs a little bit. We talked about also liking option 1 in the gold plan. And then I didn't hear any opposition to fixing the HAB rehab copay issue. So, okay, with these highlights, this should, and please correct me if I misrepresented anything. I believe this is what the group has discussed so far.
And I would just add that we would want the group to also vote on approving the proposed silver 87 plan, even though we didn't present you with an option. We'd still like your vote as recommendation for the single version that we presented.
Thank you, Johanna.
So if there's no further discussions, then I would move to approve the draft plan designs as presented based upon our discussions, to include options 1 for the bronze plan, option 1 for the silver base 73 CSR, the silver 87 plan as presented, option 2 in the 94 CSR plan, option 1 in the gold plan, and with the rehabilitation co-pays aligned with PT, ST, and OT in the silver plan, to be the work group's revised recommendation for the plan year 2026 value plans.
I second.
Is there any discussion? Then the motion passes.
Amazing. Thank you. Great. Okay. Thanks, everybody. Okay. So now that we've gotten through all of that, I want to make sure to have an opportunity for feedback on the work group so far. I know I've received some feedback on talking about prescription costs and mental health costs more in the future. So I just wanted to open this up for thoughts on areas of focus for next year, requests, or any other feedback that people have. And again, you can always email me later too, but more than welcome your comments now.
So Becca, when you say mental health visit costs, are you talking counseling or the actual provider visits?
I think, and perhaps, people who are interested in focusing on this in the future can weigh in on what they mean when they talk about this. My understanding is that it's about a general kind of feeling among consumers that some work group members have raised, that mental health is prohibitively expensive, whether they're talking about counseling or other types of office visits. I'm not really sure, but that's my understanding. It's just the rising cost of mental health care. And of course, we also know that it's not just co-pays and visit costs that are a problem. A lot of it is like network I guess I should say provider shortages and that kind of thing. Access to providers, not necessarily or only visit costs, but I wanted to kind of validate areas of priority that people have raised, and see if there are any others.
Not necessarily is something we're particularly interested in, but is VBID going to be under consideration again for 2027? Is there any plans related to expanding that? Do we have any more information on outcomes from the diabetes, or what's the thought process there?
So this is something that we talked about kind of in the earlier phases of this year's group, is the trade-offs involved in that kind of plan design. And I think, and you can let me know if this isn't what you mean by VBID, but I know in DC they kind of add a new condition each year. And so far we've done the diabetes cost sharing reduction, and they have 4 to 6 things that they're now doing. And so this iteration of the work group kind of talked early on about how we wanted to try and keep other co-pays across the board more affordable. So we opted to not focus on a condition-based cost sharing reduction approach for that, and a couple reasons. But it's worthy of discussion, probably worthy of revisiting each year. I don't know if Johanna has anything to add, but it's not explicitly on or off the table. It's just kind of something to think about.
Okay, yeah, good to know. Thank you.
Yeah.
And just in terms of the diabetes impact, that's something that we're interested in tracking. But as you know, given the lag in claims data and sort of the short duration that we've had that in place for our value plans, we don't feel we've quite accumulated enough data at this point to effectively assess that. But that is something that we want to look into when we have the data and see if we can divine an impact.
Okay, yeah, perfect. And at CareFirst, I think we appreciate you, looking into the outcomes and taking more of a data-based approach to it.
Yeah, thank you. Allison?
Yes, just wanted to say support, echo what you said as far as focusing on keeping other cost shares low in lieu of condition-based cost sharing, and I agree that we should be looking at the results. Based on our experience in DC, we do not see any evidence to support condition-based cost sharing differentials. We just don't see the evidence there. So until we can determine if there is some impact to adherence and outcomes, I think we should continue on focusing on service cost shares rather than condition specific.
Thanks, Allison. Anyone else have any hopes for next year or thoughts on how this year went?
Just appreciate the collaborative nature of the work group and the opportunity to have discussions and for sending out all of the materials in advance so that all the members can take a look and engage in the conversations. And thank you to my team for jumping in and speaking to some of the plan specifics.
Thanks, Nikki. All right. Well, again, let me know if anything comes up later. But I think for now I'll move on. Public comment now. I think everyone here is a work group member, so if you had wanted to speak up before, you probably already would have, but just in case, if there's anyone else who'd like to say something, now is the time. Just give a couple seconds of silence to allow for that. Okay, if anyone was struggling with their mute button, you probably would have gotten to it by now. So I'll move on to the next slide, which is just to just give everybody a sense of what's happening next. We're gonna release the designs for an informal comment period first. Our next board meeting isn't until January, and we want to have them finalized at the February meeting. So we're gonna just kind of split up the comment period, have a little bit before the board meeting, then the board will meet and vote, and then we'll have kind of another more formal but slightly shorter comment period after the board meeting. And then at the February meeting, they'll vote to finalize them. And then before you know it, we will be reconvening again to talk about 2027. So that's it. That's all I have for you today. Let me know again if there's any questions or thoughts. I really appreciate everyone, sticking with it and giving such good feedback. We wouldn't be able to do this without you. So thank you. And happy holidays.
Same to you, Becca. Thank you.
Thanks, everybody.
Thanks,
Thank
everyone.
you.
All right, have a good one.